Welcome everyone to this presentation on how Parkinson's can affect our emotions, presented by Dr. Jay Schneiders, who's here with us today. Dr. Schneiders is a board-certified neuropsychologist and a board-certified clinical health psychologist who has been evaluating and treating people with movement disorders for over 25 years. He has been affiliated as a neuropsychologist for a Parkinson's Disease Center of Excellence, served as the Director of Psychological Services for the former Colorado Neurological Institute's Movement Disorder Center, and has been invited to speak on Parkinson's and Huntington's to many patient groups throughout Denver and Colorado Springs. So welcome, Dr. Schneiders, and I will hand it over to you.
Thank you. Hello, everybody. I love making eye contact with my audience, and I can't even see myself on the screen now. So speaking of anxiety in Parkinson's disease, we're going to keep our fingers crossed and hope this goes fine. I hope you can all see me well and hear me well right now. I'm very pleased to be here and honored to be asked to talk to you. I think that I always want to start off a talk like this by saying the people who are really expert in this are you. The patients and caregivers are the folks who know and understand these kinds of things at a level that we professionals who don't have Parkinson's really have to intellectually appreciate and clinically appreciate. So I want to make real clear that when I'm talking today, I'm presenting research evidence or clinical evidence. It may not jibe exactly with your own experience, and that probably suggests that your own experience is more accurate representation of some of these things than the research may be. I'm going to go through the slides now, and I'm hoping that you're now seeing my first slide. And just start off by saying that clinical depression is more and different from just ordinary sadness and feelings of loss and regret, or even shame or embarrassment, although it involves all those feelings. And in Parkinson's, it's difficult to sort out what's a depressive disorder from ordinary kind of experiences that we'd all have, which are, we all have intermittent down periods. Sometimes our motivation is low. And there are, specific kinds of apathy disorders in Parkinson's that can look like depression. One of the most common things in my practice that I see is when physicians tell patients they're depressed, and the patient said, "No, I'm not depressed." And the doctor says, "Well, yes, you are." And the family says, "Yes, you are." And really what they're experiencing is the Parkinson's symptoms of apathy and affective flattening, emotional flattening. And of course, everybody has adjustment issues to any kind of condition or illness, whether it's temporary or more of a persistent one. The kinds of symptoms that are present for both depression diagnosis and Parkinson's include things like fatigue, sleep disorders. They're common in depression, and they're part of the diagnostic criteria. Slowing, loss of appetite. These kinds of things are characteristics for both diagnoses. So sorting them out can be tricky and can be difficult. Clinical depression, though, I think we need to understand that a depressive disorder is a persistent or a pervasive. It's not something that comes and goes during the day. It's a blue feeling, and it diminishes one's ability and capacity to feel pleasure and interest in things in a normal way. And for a depression to be a clinical depressive disorder, it has to impair some aspects of our functioning. Clinical depression, I'm not telling anybody, I think, anything you don't know, but the kinds of features that are common are hopelessness. That's different from feeling sad. Constant rumination about negative things, feeling worthless and helpless. What we call non-rational guilt, when people just feel kind of just always guilty. And of course, suicidal thoughts or feelings are different from and more significant than you would see in just a plain kind of emotional state of feeling down. There are several different kinds of depressive disorders. I'm not going to spend time defining all of these, but a major depressive episode is an intense, serious, severe depression. Dysthymia, which has now been described as persistent depression, is when people are feeling depressed for at least 3 months, and it might let up for a period of weeks, but it comes back. It's pretty much all the time for a long period of time. Minor depression is just a minor version of the major depressive episode. Depressive states fluctuate pretty commonly with on-off periods, and we'll talk more about that in relation to anxiety down the road. And then there are what we call adjustment reactions. And again, I'd call that a normal reaction to an abnormal state. So if someone develops an illness or a condition, we have to build our lives differently around it, and that requires some adjustment. And that may not be a clinical depression. Clinical depression, though, as a disorder, is seen in up to 50% of Parkinson's patients. And that's typically twice as many patients and people as we would normally see develop depressions in the general population, in the population that doesn't have Parkinson's. And in fact, clinical depression is much more frequent in Parkinson's than it is in virtually all other medical conditions. Mild depression, again, more than normal sadness, but less than a severe depressive episode, is extremely common in the early stages of Parkinson's. And that brings us to understanding that clinical depression actually often comes before the emergence of motor symptoms in Parkinson's, and even before the diagnosis. Sometimes years and years before, Parkinson's disease related depression can be related to the early brain changes of the disease itself. Parkinson's depression can emerge at any time during the course of a person's illness. It's not always at the beginning, and it's not always at the end. It can sometimes be chronic, and it can be recurrent. So sometimes people will feel depressed and actually suffer from a pretty severe depression. It can clear up. They can go along and feel fine, and then later on, it can emerge again. So it's not a kind of a one-size-fit-all experience for people. Depression in Parkinson's disease is more common in women. It's more common when people have a very severe motor disability. Interestingly, when people have mostly right-sided motor symptoms as opposed to left-sided, the folks with the right-sided motor symptoms have a higher incidence of depression. We see clinical depression emerge more often in patients who have rigidity and balance problems, especially at the outset, rather than tremor being their main symptom, or tremor at the outset. And then finally, when there's a lot of anxiety involved in a person's experience, depression is also more common. I'll also touch on that later. There's another risk factor for depression, and that's when we have a subthalamic nucleus deep brain stimulation surgery. And that subthalamic nucleus plays a pretty critical role in modulating depression and emotions in general. And that's the area of the brain, that nucleus, where the probe is inserted to improve the motor symptoms of Parkinson's. And interestingly, we see anywhere from the literature says up to about 10% of STN deep brain stimulation patients after the surgery will develop a depressive disorder, not just the feelings again, but a clinical depression. I've been involved in hundreds of DBS surgeries with numerous different programs, and I can say that it's been very rare in my experience to see a severe clinical depression emerge that was hard to treat. I've seen a number of them, but they're not, I would say it's more toward the 2% rather than the 8% kind of prevalence. There's also an aggressive syndrome that can develop after DBS that has a depressive quality, but it's actually anger and depression as a kind of syndrome can occur. And in very rare cases, I think I've seen 3 in my practice, we can see suicide come out of the blue after a DBS. So it's important for patients who have STN DBS to be monitoring for depression and to take it very seriously and to bring to either a doctor like me or your neurologist any feelings of self-harm or feeling suicidal after DBS. Depression in Parkinson's is not associated with the age of onset for people with Parkinson's or how long the disease has been present or even the overall severity of the disease. And that means non-motor symptoms as well as motor symptoms. The stage of illness is something that doctors compute early, mid, advanced, all stages in Parkinson's, and depression can occur in any of those. So it's not specific to them. When people are depressed in a clinical sense with Parkinson's, we see a more rapid progression of motor dysfunction and motor symptoms. There's earlier cognitive problems, memory and thinking problems in depressed Parkinson's patients. Depression in Parkinson's is associated with a greater risk of developing a Parkinson's dementia down the road, and certainly impairs activities of daily living, ADLs, more significantly. There's an increased mortality risk, which is something that's reported in the literature, and I think not something specifically to be too worried about as a specific thing. But interestingly, caregiver depression also accompanies the patient's depression. Not something for patients to feel guilty about, but something for us healthcare providers to be aware of and not to ignore caregivers and caregivers' emotionality and reactions and feelings when we're treating a patient with depression and Parkinson's. Interestingly, to me, depression is the #1 factor affecting quality of life in Parkinson's. There are some studies that show that anxiety is at least as disabling for people and may affect quality of life pretty close to that, but it's the #1 factor that patients report being a negative factor in quality of life. And it's often a greater source of disability for Parkinson's patients than the motor symptoms, the tremor or the gait disorder are. Now, most of us, when we're struggling with emotional reactions, we assume everybody else is feeling okay with whatever we're trying to manage or deal with, and that there's something going on with us that's different and wrong. And maybe I'm just making a statement about myself, but I think there's a way in which we tend to be more thinking that our reactions are less normal than other people's. And what normal is really important when we think about anxiety disorders. I'm going to switch to those for a moment here. Everybody worries, everybody's scared of certain things, but anxiety is really different from fear. Fear is always fear of something specific. So if I see a lion coming at me, I feel fear. I'm afraid of the lion. If I'm sitting home having dinner in Englewood, Colorado, and I'm just feeling there's something wrong, something kind of unsettling and disquieting, that's more anxiety. It's just free floating generally. It's hard to pin down what it's about. And even though it's a common, very normal sort of reaction of people to things that are uncertain in life, an anxiety disorder in Parkinson's is something that's, again, like depressive disorders, a more significant set of symptoms than just ordinary uncertainty. They're fairly common, anxiety disorders in Parkinson's. The numbers you're going to see always vary in studies. Here, 17 to 43% of Parkinson's patients are thought to suffer from clinical anxiety disorders. And that's because studies use different criteria for defining anxiety, and they look at different groups of patients. But we do know that anxiety is significantly underdiagnosed and underappreciated in Parkinson's. Doctors and healthcare providers ask about depression at every visit, but it's harder to pin down anxiety in some ways, and so it tends to get overlooked. Very common, over a third of patients with depression will also have anxiety. And again, it's tough to sort out because a lot of symptoms of anxiety disorders outside of Parkinson's involve things like tremulousness and feeling shaky, and that sort of thing. And those, of course, are cardinal symptoms of PD. Just like depression, anxiety disorders can emerge years before Parkinson's disease and actually be related to the condition itself. There's a number of studies now that show in the general population, people with anxiety disorders, again, not just nervousness, but anxiety disorders, are more likely to develop PD than non-anxious people. Anxiety disorders typically occur in persons who have a greater overall severity of PD, but they also are individually related to very specific symptoms of dyskinesias and motor fluctuations. When people go into an off period of motor fluctuations, as many as 80% of studied patients with on-off fluctuations will become significantly anxious in that off state. When they go back on, the anxiety goes away. And almost 40% of patients in the off period will have actual panic attacks. So again, this is a specific factor for Parkinson's-related anxiety. We see anxiety disorders more often in Parkinson's patients who have gait problems and postural instability rather than tremor-dominant patients. Young onset patients, 50 years old, are more likely to show an anxiety disorder than a patient in his or her 70s. I'm going to talk about coping styles in a minute, but people who have a more passive coping style rather than an active one are commonly more anxious. We see anxiety disorders when people have sleep apnea and restless leg and REM behavioral disorders symptoms in Parkinson's. In fact, in the general population, obstructive sleep apnea commonly can cause anxiety disorders. And instead of needing to treat the anxiety, if we treat the apnea, the anxiety goes away. Not surprisingly, cognitive disorders are related to anxiety disorders. That's a two-way effect. So people with more problems with memory and thinking tend to be more anxious, and people who are more anxious tend to have more difficulty with their thinking and their memory. Again, women are more common to show these disorders, and generally, and not surprisingly, overall severity of Parkinson's will find itself associated with greater anxiety. Interestingly, though, the duration of Parkinson's is not related to the emergence of anxiety disorders. The longer a person suffers from Parkinson's, in other words, doesn't lead to anxiety disorders. There are several kinds of anxiety disorders we see in Parkinson's. Again, I won't go through all the diagnostic criteria. Generalized anxiety disorder is when people feel a persistent state of anxiety pretty much all the time that doesn't let up. It's not really related to anything specific, and it really just doesn't go away. Phobias, specifically social phobias, are really focused anxiety. You can have a phobia about needles. I treated patients with needle phobias. You're all aware of people, and maybe some of you have spider phobias or snake phobias. But a social phobia is the more common occurrence in Parkinson's, and that's where people feel they're being judged, they're being watched, they're being made fun of or thought less well of out in public because of their Parkinson's symptoms. And the feeling state is not related to people telling you negative things about yourself. It comes from inside. Panic disorder, again, panic attacks are immediate, out of the blue, abrupt feelings of terror. You're going to die, you're going to go crazy. They last for a few minutes and then go away. And then there's this garbage can category of non-specific anxiety disorders. And that just means basically that the anxiety syndrome in Parkinson's can have a variety of different features. It doesn't need to be more discretely specific to the other kinds. Anxiety disorders can be persistent, as I said. They can pretty much exist all the time. We can see them again be episodic, particularly with on-off fluctuations, and then the social phobia can create avoidance where people pull back from the world. Anxiety states in Parkinson's typically fluctuate rapidly throughout the day. So even with some of the more generalized anxiety, we'll typically see it get better and worse throughout a day. And as I said, with on and off fluctuations in the off period, people commonly feel anxiety. It's interesting that anxiety contributes to freezing of gait, and so that treating an anxiety condition can actually sometimes improve gait disorders in Parkinson's. Anxiety is an enormous factor, and it is for anybody, affecting the overall quality of life. And again, there are different studies, but some have shown that even more so than depression, and certainly than physical symptoms, anxiety just seems to make people's quality of life feel lousy. There's a sense of stigma about being anxious. People feel like they're shaky, they don't look normal, they tend to isolate, just don't feel well in general. And as I say, mobility problems just typically get worse. And so there's a feedback loop of doing less well with anxiety. There are only a few studies of COVID-19. I wanted to just put something in here, but Parkinson's disease patients have been shown to be having much more trouble during the COVID period, and that's not surprising. PD-related anxiety is related to not being able to reach our doctors or go in for an appointment or to get medications on time, being afraid of getting the infection when you already have an illness. So there's a kind of naturalness about anxiety feeling worse. But severe anxiety states are also more common in Parkinson's during this COVID period. The one study that's been done has shown about 26% of Parkinson's patients have reacted to the COVID situation with severe anxiety, really severe. And that's in comparison to about 5% of people without Parkinson's reacting that way. I think one of the more interesting findings here was that 60% of Parkinson's caregivers reported increased anxiety during COVID, with almost 5% reporting severe anxiety. And that's probably because some of the coping access to coping strategies and activities for caregivers is also limited during the COVID quarantine. I want to mention embarrassment, guilt, and shame. They're related to anxiety and depression and are important to be thinking about in Parkinson's. Feelings of embarrassment typically emerge when we feel we've done something, minor that's wrong. We knock over a glass of water or something and we feel a little embarrassed. Guilt is when we feel that we've done something wrong. And shame is more of an internal kind of feeling about ourselves not being as worthwhile. Guilt in Parkinson's is pretty common. It's common for normal people to feel that they're a burden to other people, even when they're not. And it's related to feeling I did something bad or I'm doing something wrong. So it's about behavior. And, the way we try to fix guilt is to make things better. We do something to improve something that we've done. But shame is a more malignant kind of thing. It's a feeling of I am bad. It's something about myself is not good. And the common ways that people try to deal with shame are to disappear, to escape. And that compounds anxiety and depression in Parkinson's. And so again, when people just ask if you feel panicky or anxious or depressed, it doesn't really capture this whole issue of shame, which needs to be looked at and certainly needs to be helped with. It's very common in Parkinson's. Over a quarter of studied patients will report significant feelings of shame. And I think that one of the biggest things that we see causing that is the deteriorating body image, where people feel again, just shameful about themselves. It's not just my body, it's me. And the feelings of dependency and feeling one needs more help to get by in the world. One doesn't feel as good about oneself. All right, with these different feeling states, when do we ask for help? Well, when it's more than just a bad week, when shame or anxiety or depression persist, when they hold on, and when they start to affect our relationships or our work, and basically, if we start to feel our sense of self or being ourselves in the world just doesn't feel right anymore, it's time to ask for help. Now, I'm going to just talk a little more briefly because you have this on your slides, and I don't want to go over too much in my time. All psychologists go over, we'll talk forever unless we're stopped by somebody, I think. But I'm going to touch on a couple of different approaches to treating anxiety and depression in Parkinson's. Exercise actually is a very serious and helpful, beneficial therapeutic intervention for depression and anxiety. And it does all these different things in the brain. It actually improves brain function. I used to roll my eyes when my primary care doc would say, Jay, you got to get more exercise. And I'd go, I sit all day. How am I supposed to get more exercise? You need to get more exercise. But it actually turns out that exercise promotes brain health in all sorts of ways, actively and specifically. In Parkinson's, exercise therapy to improve depression and anxiety has to be regular and continual. It's got to be structured, it's got to be planned and repetitive. It's not just kind of occasionally working out or doing something. And a typical program for exercise might be strengthening and walking and stepping movements, stretching 2 to 3 times a week, maybe, 3/4 an hour, an hour. The more aerobic the exercise is, the more powerful the antidepressant and the anti-anxiety effects are. And I just want to mention that even aquatic exercise has been shown to reduce symptoms of depression in Parkinson's. Yoga, a very powerful medical technique, it actually has been shown to help with refractory seizures more than medications in certain patients. But in Parkinson's disease, we see clinically significant improvement in anxiety and depression. And it also seems to keep depression from getting worse in people who already do feel depressed. There are anti-inflammatory effects in the brain, and a typical yoga regimen would be 90 minutes weekly or twice a week of good solid yoga. It's not the hot yoga where people are cranking up the heat to 200 degrees. This is the standard positional yoga kinds of activity. Qigong and Tai Chi, most people know about Tai Chi. These are mind-body approaches that combine fluid movement with mindfulness, and they both have been found to be effective with depression and to some extent with anxiety. Repetitive transcranial magnetic stimulation. I'm not going to spend a lot of time on this. It's now being, patients are hearing about it and seeing it. It's where a doctor takes a magnetic coil and moves it around the brain. There have been a fair number of studies that have been looking at this, and a couple of them have suggested that there's short-term helpful effects with depression. But I think it's very controversial at this point. It can cost $6,000 to $12,000 a year. 50 treatments, 30 treatments can be needed of an hour each. And it really doesn't, it hasn't shown yet a more significant effect than standard treatments of depression. Psychological therapies, particularly cognitive behavioral therapy, which is a time-limited, very organized, sometimes 10-week focus on coping strategies and our attitudes and the ways we sometimes distort things and feel worse, is a very well-established and helpful therapy. We talk about coping styles. Improving coping styles seems to help. Some people have more passive styles. They tend to avoid thinking about the problems or the things that they struggle with. Other people are more active and they approach the issues and they go right after them. And it's interesting that coping styles in PD are significantly associated with positive effects on the disease. The more active the coping style, probably the better people do with Parkinson's. I'm going to move through the final slides here a little bit more quickly. Drug therapies, about a quarter of Parkinson's patients are on antidepressants. They're tricky. They probably help with certain symptoms of depression. Part Parkinson's depression is probably more spread through the brain and in different areas than just typical depressions are without Parkinson's. And so the antidepressants haven't been shown to be as robust in affecting um, positive changes on depression. And there are a lot of side effects, including worsening tremor with some of them. So they have to be very carefully used. They're not happy pills. They generally either exert a more calming effect to agitation, or they are more energized when people are feeling their energy level down more. There's a big placebo effect with antidepressants, and that's good. Placebos are our friends. They help our brains and our bodies heal and move in positive ways. They have demonstrable neurologic effects. They're not fake or made up. And placebo effects are much stronger for Parkinson's disease patients than in the general population, interestingly, which is, again, is a good thing. So if you decide you want to try an antidepressant, it's certainly worth trying and to talk about with your doctor. Make sure you're aware of potential side effects and risks, and make sure you have a realistic expectation. Again, they're not happy pills. This says, I think the dosage needs adjusting. I'm not nearly as happy as the people in the ads. There aren't any medications that specifically target anxiety disorders in Parkinson's. The SSRI antidepressants sometimes are helpful, particularly more with panic. And the old drugs for anxiety like Valium and Xanax and Ativan, the benzodiazepines are quite problematic and sometimes dangerous with Parkinson's. And so they're typically not prescribed these days. So I say medication is sometimes indicated and can help, but here's the cartoon. And the ad says, ask your doctor if taking a pill to solve all your problems is right for you. We live in a medicalized society. And I think it's a sad thing that everything is considered, if your doctor can't give you a pill for it, you're not getting good treatment. Well, there aren't pills for dealing with life problems and sadness. And many of the conditions that we struggle with in our lives that cause depression and anxiety are every bit, if not more effectively treated with psychological therapies. Cannabis. I have a big section here, which again, I'm running out of time. You can go through the slides yourself. Cannabinoids receptors and cannabis is being thought now to have some effects on the brain that may be positive in Parkinson's disease, might even be neuroprotective. But the key thing here is that there's really insufficient evidence about the benefit. You're going to see that cannabis might be helpful with tremor and rigidity, sleep disorders, pain, and Parkinson's. And the problem with the studies is there's a fair amount of bias in the studies. And again, I think individual differences are probably important here. People react differently to marijuana and cannabis. Some people have reported feeling better with anxiety and depression, but certainly many people feel worse in those respects. It does seem very clear from any study that's been done, small or large, that dyskinesias are not helpfully affected by cannabis. A lot of problems with marijuana. In the old days, hippie days, people thought smoke a little pot, no big deal. Now there is a big deal. Certainly driving is impaired. We see psychosis. There are many negative side effects, some extremely severe with cannabis preparations. And we know that people who are using cannabis have poorer cognitive function relative to people who don't. I cannot do in Colorado a good diagnostic neuropsych exam on people who are using cannabis at regular high doses, because we know that it affects cognition adversely. It should never be used for nausea in pregnancy. It's dangerous, and in cases of heart failure, there are very severe problems using cannabis. It interacts with lots of medications. About 18% of normal adults can become classically addicted. They're spraying some of the products or the plants with organophosphates and sometimes even lead pellets weigh it down and get more money for the amount of plant that's being bought. And people have gotten organophosphate poisoning and even lead poisoning on rare occasions. There's been a study of dispensaries in Colorado, which went around and they show how much THC is in each dose of the cannabis that people buy and the different receptors that are affected. And the scientific studies looking at 100 different, I think it was dispensaries, found a zero correlation. Doesn't mean the people who are selling the cannabis products are lying. I think they believe what the labels say, but it's an absolute crapshoot, and it's essentially made up. So, feeling blue, feeling anxious is normal at times. Depressive and anxiety disorders are different from that, and one should never hesitate to bring these up to the attention of your healthcare provider, because they typically are underdiagnosed, and your neurologists are doing their very best to control the disease process itself, take care of all of the other kinds of symptoms that go along with it, from the movement symptoms to sleep disorders. And so you're going to have to be the one quite often to say, hey, I'm concerned. I know, that this is may not be your specialty, but can you send me to somebody I can talk about these kinds of feelings with, and not feel weak or that's deficient, or there's something to be embarrassed about or shameful because you bring these things up. So I hope you see from these slides, virtually everyone with Parkinson's gets saddled with these feelings at any rate, and quite often with these disorders, and there's no shame. And there's certainly every hopefulness and benefit to seeking help with them. And then finally, just consider non-pharmacological treatments. Pills aren't always or necessarily the best way to go, and certainly the only way to go. They can be helpful, and it's worth considering antidepressants and other medications, but consider psychological therapies, exercise therapy, yoga, these kinds of things. But do be wary. Be wary of using cannabis these days. And in Colorado, I'm going to just tell you, I had about an 80-year-old patient. She must have been about 5 feet tall. This was back when we just had the medical marijuana here in Colorado, and the dispensaries were popping up everywhere. And she came in and she told me she was got a medical marijuana certificate. I said, well, and her name wasn't Mabel. I said, Mabel, how on earth did you get a medical marijuana certificate for Parkinson's? And she said, well, I got it for my pain. I said, but you don't have pain. And she said, I know, but he said he had to call it pain for me to get the medication. So I said, well, what happened? She said, well, I took it and it made me stupid. I said, well, what'd you do? She said, I flushed it down the toilet. I don't need to have Parkinson's and be stupid too. And this, I wish I could have gotten this little lady out to the high schools to talk to our high school students about cannabis, because in fact, that's a common side effect of it. So be wary of magical solutions, herbs, and other kinds of things. They can be problematic and harmful, but do seek out care and talk to people about feelings and struggles you have in these different ways. I guess I think that's the end. Yeah.
All right.
So,
I will pop back off, and you can go ahead and turn off your share screen, and we can see us big and beautiful. Okay, so we're now going to open up for a couple of Q&A. We have about 5 minutes for that. So if you have a question, make sure you navigate to the. It's fine. Navigate over to the Q&A and type your question in. We do have one question here from Paul, and he is asking about a certain brand of medication or class of medication that you do not recommend, but it's worked for him for nighttime movements, and is wondering if there is an alternative that you would suggest.
What's the class?
So it's clonazepam.
Yeah, clonazepam is a benzodiazepine. The benzodiazepines I don't recommend for anxiety, okay? Clonazepam is, in fact, sometimes it's the only medication that works for REM behavioral disorder and sometimes severe restless leg syndrome and Parkinson's. It's absolutely indicated if your doctor prescribes it and feels it's safe for you. The one problem with it is it carries a fall risk. When people get up in the middle of the night, there can be some confusion, but trust your doctor on that. It's absolutely, and I'm sorry I didn't mention that in the slides specifically, but for nighttime sleep problems, it's absolutely appropriate in Parkinson's. It's the only place I like to see it, actually.
Awesome. Okay, we have another.
Thank you.
Yeah, we have another question from Anne, and she's asking about, she asks, do you know anything about Happy Light? And she says that she thinks it's used for sleep problems.
No, but I mean, on the face of it, a Happy Light sounds good. I'm guessing that there is light therapy for certain kinds of sleep disorders, and the brain's sleep-wake clock is set by nighttime. When darkness hits the retina, the clock turns on, and then in the morning, when light hits the retina, the clock sets. And so that tells your brain when sleep time is and when awake time is. And some people who have disruptions in their sleep-wake cycle, so sometimes they can't sleep until 4 a.m. and sometimes they sleep at 8 o'clock at night. You can use bright light therapy at a regular time in the morning to reset the clock. That's all I can imagine that might be. And I apologize if I'm wrong about that.
No, that's fine. So I know our Q&A can sometimes lag a little bit. So we're almost closing out anyways. So
I will just make one more comment to Paul's question, and that is that no presenter, including me, is a substitute for your own neurologist and movement disorder specialist. And it's always proper to raise a question about something like a benzodiazepine, but you really can and should trust your own physician about their recommendations.
Awesome, thanks. Okay, we did get one last one come in, and this one's from Brian. He says, any studies on benefits of being in nature, mountains, water, etc., for PD?
Oh, I think there's a benefit for being in nature for every human being. And I think for PD, I don't know of a single study about it, but if you just think about it, we think that PD so often restricts our ability to be out in the world as fluidly as we would ordinarily be, perhaps, or would like to be. And so I can't imagine, but that being out in a natural setting wouldn't have even more enhanced effects on our mood and our feelings and our sense of comfort in ourselves.
Awesome. So I'm actually going to go ahead and close out right now. And if there are any questions that come in afterwards, I'll let you know. Okay. But thank you so much for your presentation. This is a topic that I know affects so many people and may not be quite as prevalent in the webinars. So thank you so much for presenting for us.
You're very welcome.